The surgeon is responsible for the welfare of the patient. The surgeon should go by and see the patient the night before. The surgeon should check the leg for any wounds which would cancel the surgery. The surgeon should check the range of motion of the knee, go over the x-rays again, and be sure the x-rays are available in the operating room the following day. To reduce the tibia, you need 110 degrees of flexion. This can be achieved by putting a bump under the thigh, not under the popliteal area. It can be achieved with a stirrup. It can also be achieved with a figure 4 position. The figure 4 position makes approach to the tibia much easier. It also allows you to control the fracture for easier closed reduction. The approach to the tibia is through the patella tendon. Some people go on either side of the patella tendon, but most go longitudinally through the patella tendon. You can palpate the patella tendon by holding either side and thereby making your incision in the middle of the patella tendon. As you start doing sign, you will notice that your incision is rather long, and as you become more experienced, your incisions will decrease. The first step is to test stability of the tibia. You must test in different planes because sometimes the nail will go down posteriorly and the tibia will feel stable in the AP plane but not in the lateral plane. Your next step is to make the entrance hole. Of course, if it's an open fracture, you must debride the open fracture first. The entrance hole can be made between the tibial tubercle and the knee. Do not enter the fat pad or you will enter to the knee. This hole was made previously. It is probably a little proximal. The curved awl is used to initiate the hole. The curved awl is angled anteriorly and sunk to the hilt. Once you've made the entrance hole, you must communicate the entrance hole with the canal. Our pilot reamer is used to do this. The pilot reamer is taken down through the pataphysis to the canal of the tibia. After that, reaming will take place. Sign has now developed a new configuration to all of our reamers. Initially, we only had our 7mm as a pilot reamer. We now have the same configuration in all of our reamers up to 12mm. These reamers were designed first for a fin nail with a blunt tip. We have found it is advantageous to have the same configuration as the pilot reamer for all of our reamers. Once you've reamed, it's time to choose the size of the nail. The diameter of the last reamer where you achieve chatter is noted. You can drop down one size or you can drop down 2 sizes for the width of the nail. The length of the nail can be determined preoperatively using a template by measuring on the uninvolved leg or measuring how far the reamer goes down into the shaft. We've revised the sign instruments in the past year. The L handle is now 25mm wider. The locking bolt is much more secure when it fits through the L handle into the nail. We now assemble the nail. We take the L handle, followed by the new locking bolt, place it through the L handle. In the tibia, you'll interlock through the medial side. In the femur, you interlock through the lateral side. So you place the L handle on the proper side for interlock. The locking bolt is then screwed into place, making sure that the tabs intersect properly. After hand tightening is done, we use the wrench to secure a good tightening. Nowadays, we want you to put good pressure on this junction. After you have placed the L handle on the nail, you then place the target arm on the L handle. The proximal target arm is placed first onto the L handle using the shoulder cap screw. It is hand tightened first, and then the hex wrench is used to further tighten. Following this, we connect the distal target arm to the proximal target arm. We know which holes we use by placing the alignment pin through the distal target arm and through the slots of the nail. You then look down to align the slots of the distal target arm and the proximal target arm and place the distal cap screws through the two holes, uniting the proximal and the distal target arm. It is a wise idea to use gravity to place the distal cap screws through the two target arms. After the hand tightening is done, we then tighten with a hex wrench. First, check the alignment, and then use the hex wrench to tighten the cap screws. Finally, you check alignment again, and this alignment is perfect. We are now ready to remove the target arm from the L handle. The hex wrench is used again to untighten the shoulder cap screw. The nail is now ready to be placed through the tibia to stabilize the fracture. You're now ready to introduce the nail through the entrance hole in the tibia. It's very important to use a tissue protector. The tissue protector will keep the nail from striking the skin or even rubbing on the skin. The skin contains bacteria which can contaminate the wound. The tissue protector is placed over the nail and the nail is introduced through the entrance hole. There are many ways that the nail can be placed down the canal. You place the nail down the canal to the fracture site. The assistant will reduce the fracture and the nail carries on down through the distal fragment. It is very important to recognize that your assistant, or it may be the lead surgeon, has the most important role, because lining up the fracture is very important to putting the nail down through the fracture. The nail can be placed down through the canal of the tibia by light pressure. It can be placed down the canal by light taps, tap, tap, and we twist a little bit to make sure that the nail does not get hung up in the canal. This is a very important part of the procedure. So you introduce the nail down through the fracture site, and you can remove the tissue protector when the L handle reaches the point where it has introduced the nail into the entrance hole. The rim is important to note. This ring is about 4 millimeters higher than the tab. So if you place this rim right at the edge of the bone, your nail will be placed possibly too deeply for easy removal later. So remember the 4 millimeter difference between where the tabs of the nail are and the ring on the L handle. During the insertion of the nail into the tibia, you must be sure the locking bolt is tight. During this insertion, you check the locking bolt tightness frequently, and at the end of this insertion into the canal, you be sure that the locking bolt is tight into the nail. Only a few degrees of rotational movement will throw off your hole. Once you have placed the nail sufficiently down the canal through the fracture site, you're ready to do the distal interlock. Sometimes in a proximal tibia fracture, the nail is likely to penetrate the posterior cortex. To prevent this and to guide the nail down the canal, you can use a blocking screw in the posterior part of the tibia to guide the nail down the canal. You may use a sign interlocking screw for a blocking screw and then remove it after it has done its function. The most difficult part of the sign system is the distal interlock. We have designed new instruments and we have devised new techniques to make this interlock more efficient and more fun. The sawbones is a little loose, so Gene Dillner will hold the L handle to stabilize it. Ordinarily in the actual surgery, it will be a tighter fit. The first step is to place the target arm on the L handle. This is a junction which tends to orient itself as you hand tighten. Do not force it and cross thread. Note the configuration of this junction. You then tighten with the hex wrench. You're now ready to accomplish distal interlock. We like to do the distal interlock first. The reason is that you can rotate the nail to accomplish interlock. If you do the proximal interlock first, you cannot rotate the nail to achieve interlock distally. The first part of the distal interlock is to use the alignment pin to mark a hole in the skin. Once that is done, you spread the tissues using a clamp all the way down to the bone. You then use a periosteal elevator. I always take a periosteal elevator, put it through the incision, and scrape it up and down to be sure that the cannula will rest securely on the bone. You then take the cannula and place it through the distal hole. Often some tissue will get in there and you use a clamp to be sure it is out. Some people will tap the cannula to be sure it is secure into the bone. The next step is to make the small hole. We use the small drill guide to make the small hole. This can be done using a hand drill. The hand drill is then placed through, and the drill is then placed through the small drill guide to make the hole in the tibia. It's very important to pay attention and give stability on the other side of the tibia, because you don't want to go through and hit the nail. We have done a study on the drill bits. We were having trouble with the drill bits becoming dull. They do not become dull by drilling through bone. They become dull by drilling through bone and hitting the nail. When you get a ding in the drill bit, the next time the drill bit heats up, and that is what causes the dullings. We have done our drill bits 210 times through animal bone and through composites without noting any dulling. So it's very important to handle your drill bits appropriately. These drill bits should be handled appropriately during cleaning, sterilization, as well as by the surgeon to avoid getting dings at the end of the drill bit. Once you have made the small hole, you have several choices. You remove the small drill guide and place the large drill guide in. Thank you. You can then use the large drill bit to make a hole, but we prefer to use our step drill. Our step drill has been improved now, so there's less breakage. It has a point which will follow through this hole made by the small drill bit, and then a larger end to make the larger hole in the tibia. You then place it through, and by hand enlarge the hole. It's very important to do this carefully to get some stability on the tibia, and you'll feel it as it begins to go through the bone. We're now looking at other instruments we can use to clean out the hole. After you've gone through, if you ever go through so far that the step drill stops, you're now in the slot of the nail. It's very important not to force the step drill when you reach that, but to remove it very carefully. Once you have removed the step drill, you're ready to use the slot finder. The first slot finder you use is the solid slot finder. We have 3 slot finders. We use the solid slot finder first with the target arm. We place it through. Notice that I'm doing this in the plane of the bone. And when you put the slot finder through, don't keep moving it like this. Just place it straight on through, and you'll know you're in the slot of the nail when you only get about 20 degrees of rotation. Notice that when I first started to do this, this slot finder went all the way around. I was not in the slot of the nail. So I pushed it through into the slot, and now I'm in the slot of the nail Note you have about 10 to 20 degrees of rotation when you're in the slot of the nail. The next step is to take the cannulated slot finder. The cannulated slot finder, by its name, is cannulated. So you will place this through into the slot of the nail to make the hole on the other side. The cannulated slot finder is a little wider than the solid slot finder. So sometimes you have to clean out the hole between the solid slot finder and the cannulated slot finder insertion. Once you're sure the cannulated slot finder is in, you know again by the sign feel, you take the small drill bit, place it through the slot finder, and then make the hole in the far side of the cortex. Once you've made this hole in the far side of the cortex, you're ready for the depth gauge. You remove the drill, use the depth gauge. The depth gauge is used with the cannula, but you'll first place it through the slot finder to the other side. It just marks the hole at this point. So you remove the slot finder. A frequent mistake made is not to remove the drill guide and measure using the drill guide. So you must remove the drill guide. The reading is done using the cannula. There are marks on the depth gauge to determine the depth of the hole. This one measures about 25 millimeters, but we'll use a 30 millimeter screw. We would like to have the screw a little proud so that it's much easier to remove. I've selected a longer screw to show you the anatomy of our screw. It has threads on the wide end for the near cortex, and it has threads on the far end for the distal cortex. This provides good stability. We also do not have threads in the middle because this gives a stronger screw. We'll now use the screw size that we picked up and place it through the hole. As it goes down the cannula, you'll feel the screw go through the nail. It goes through the slots of the nail, and then you screw it in. I always move the cannula up to make sure that I don't go too far. These screws are very powerful, and they can go all the way through if you're not careful, especially in osteoporotic bone. Once you've placed the screw, the ideal amount of screw showing is right here. It's about 3 millimeters. Once this screw is placed, you place the alignment pin into the head of the screw. A surgeon will then hold this steady to make the next hole and to make the proximal hole. We're debating now how many screws are necessary. We look at our database, and I see many fractures are being treated with only one screw distally and one screw proximally. We're finding that we've not had a failure this way, so this is under continual observation by us. Your reports are going to help us solve this question. After stabilizing the alignment pin, we then move to the proximal. It is very important to recognize in proximally you do not use the slot finder. The first step is to make the skin incision. I just used this alignment pin to dimple the skin, and then you make the incision down to the bone, take the periosteal elevator. Sometimes I dissect through the soft tissues with the periosteal elevator and remove the periosteum. After this has been accomplished, you take the cannula, place the cannula down through. Again, we'd like to stabilize the cannula, so a few taps sometimes are helpful. The next step is to do identically the same as we did with the distal interlock. We take the small drill guide, place it through the cannula, and then place the small drill bit through the small drill guide and drill all the way through to the other side. It's more difficult to use the slot finder in the proximal area because of the metaphyseal cancellous bone. So this goes all the way through the other side. I can feel it this way, but usually a surgeon can know when he's through the other cortex. I then withdraw and use the slot finder, again replacing the small drill guide with a large drill guide and placing the slot finder through. Remembering that you only have to go through one cortex. Many times in an osteoporotic patient, this step can be omitted, but I don't like to do that because sometimes the bone is stronger than you think and the screw will be proud. We've now gone through the cortex. We remove the step drill, being careful not to hit the nail. The next step is the depth gauge. We place the depth gauge through even with the... I'd like to point out a mistake I just made. I was trying to put this depth gauge through and I hit the nail. It turns out that the alignment pin is not secure in the end of the screw, and so when it is, it's an easy task to accomplish placing the depth gauge through the bone. It is measured using the cannula. This measures 46, so we'll use a 50. We remove the depth gauge. Again, we have to keep the alignment pin in the end of the screw, then we place the screw through the proximal end. You'll feel it go through the slot in the nail. Again, lift up on the cannula to be sure you haven't gone too far into the bone. This is about far enough. You'll be able to find it again if you want to remove the screw and the nail. Now you have to make a decision about one screw or two screws proximally. We'll just do one screw now, but if you wanted to do the other screw, you still keep it oriented down here and do the more proximal screw in the same manner. Now you have the fixation of this fracture in this sawbones tibia. You can see there's still a little rotation. We know that tension and compression causes accelerated fracture healing. Our sign surgeries seem to heal a little faster, and this may be due to the fact that we have slots instead of holes. This allows for more motion at the fracture site, but I don't believe it allows for excessive motion at the fracture site because we have a low incidence of non-union. After this fixation has been accomplished, we remove the target arm and we remove the locking bolt. When we get through with removing the target arm and the locking bolt, we put bone wax in the end of the nail. This means that fibrous tissue cannot grow through the end of the nail. We do not have an end cap in the sign nail, and we have not found it necessary. Many of our sign nails have been removed without a problem. I'd like to demonstrate what you do when you can't get the solid slot finder through the slot in the nail. You can see we're not lined up. The first thing you do is recognize the situation and remove the target arm from the L handle. Once the target arm is removed, you then take the curved slot finder. Note the configuration of the curved slot finder. The surgeon who is using the curved slot finder will also control rotation of the nail. We'll move this back around, this cutaway, so you can see what happens. It's rotated away, you can't see, and you rotate it, and the curved slot finder goes right through the slot in the nail. You then move it both sides longitudinally to its extreme to center the slot in the hole. You remove the curved slot finder and take the solid slot finder, place it through the slot of the nail, maintaining the same amount of rotation of the L handle. Once the solid slot finder is through, you take the cannulated slot finder, which is used to make the hole in the far cortex.